This is a simple interrupted suture. The cord length is the distance from the tip of the needle to the swage where the suture is attached. You should bisect the cord length with the incision to ensure equidistant placement of the entry and exit points of the suture. By supinating the arm and performing the suture as I've just described, the deeper tissue will help push up on this incision, helping to evert the wound. After tying 4 knots, the suture tails can be cut. Let's look at that again up close. Perpendicular entrance into the skin, supination, perpendicular exit, equidistant exit and entry points that match the cord length of the needle. This first knot is a surgeon's knot, meaning it has 2 loops. Subsequent knots have 1 loop. And you can see that the tension on the suture is enough to bring the wound edges together and provide a little bit of eversion, but not enough to strangulate the tissue. Placing a vertical mattress suture is similar to the simple interrupted suture in that initially enter the skin perpendicular, bisecting the cord length, but instead of tying the knot, make a second pass very close to the skin edges. It's a common error to make the far bite too close and the close bite too far. When sewing up wounds on the face or with other fine suture, it's important that the small bite near the edge of the incision be extremely small. It's helpful to make a small pulley with the needle driver so that these small tissue bridges don't get torn. You can see that happening here. And when tying this knot, the skin edges should be approximated closely together, but it should not be overly tight. The goal of a vertical mattress suture is gentle eversion of the skin edges and close approximation without a level mismatch. It should not be so tight that it heaps things up into a wall of flesh. We'll see that again here, closer up. Entering the skin perpendicular, bisecting the cord length, exiting the skin equidistant from the entry point. The far bite should match the distance of the cord length of the needle, and the near bite should be very close to the skin edge. Here you can see that pulley, so that we're always pulling the suture in line with the passes of the needle. Snug but not too tight. Next is a horizontal mattress suture. This is used extremely infrequently in closures of lacerations or incisions on the head and neck. However, it's important to know the principle behind this in case it's needed. This type of closure is more commonly done with fascia or wounds that are under some tension. This is essentially 2 simple interrupted sutures next to one another, closed in a circle. You can see that there's some bunching of the skin, and there may be some decreased blood supply to the area inside the suture. That's why this is maybe better suited to things like fascia and other tissues that aren't as vascular. This is a running subcuticular suture. This can be helpful for skin closure when there are several other deep sutures already helping to hold the skin together. The entry point is distal to the beginning of the incision, and the needle should be placed through the skin somewhat obliquely to its surface. That will help with maximizing the eversion. You can see that the entry point for each pass is a millimeter or so backed up from where it would normally be directly across. The suture is then passed from side to side, making a shallow arc oblique to the surface of the skin. It's important to make sure that the entry and exit points of the needle are all at the same depth. If there's a small level mismatch when performing this closure, it's nearly impossible to fix without doing it all over again. Typically, this type of closure would be used for a longer incision and is often favored when closing thyroid surgery incisions in the neck. This is the final pass within the wound. The last pass will again go through the apex and then out through the skin. These free ends can then be either taped down with steri strips, glued down with dermabond, and you can see how that brings everything together. This is an inverted simple interrupted suture. You can see the entry point goes from deep to superficial and then superficial to deep. By doing it that way, the knot is then at the bottom of the suture and deeper in the wound, making it less likely to extrude through the surface. Although this is being shown with a nylon suture, this would not typically be done with a permanent suture like nylon or Prolene. This would be done with an absorbable suture. These types of sutures are helpful in wound closure because you can distribute the tension on the wound very evenly without having any external stitches. External stitches are often placed afterwards to better align the wound edges. When cutting the knot, it should be cut right on the knot. This is a running suture. This is essentially multiple simple interrupted sutures that are placed without cutting both ends of the suture in between passes. So the beginning of it is the same as the simple interrupted suture, and you can see here the next pass is leaving the tail of the suture intact, and again bisecting the cord length. And this will cause the suture to essentially be a spiral, holding the wound edges together. The main advantage to a suture like this is that it saves some time by not having to tie knots all along the length. So it tends to be favored for incisions that are long and straight and flat. Tying the knot at the end of this suture is a little bit different from what's normally done because there is a loop instead of a single strand. grab the midpoint of the remaining loop, tie the knots as usual, and then cut the loop and the free end. This is the same sort of suture, but it will be locking. So this is a running locking suture. The locking component of it can be helpful sometimes for wound diversion or for hemostasis. So the beginning is the same as before, a simple interrupted suture. One end, the free end, will get trimmed. And then it will be run in a very similar manner to the running suture. But instead, the needle will be passed through the loop made by the suture. This will cause the lock. This type of suture is helpful for post-auricular incisions, and I like to use this for closure of the hemitransfixion incision when performing septal surgery. You can see that I'm able to do most of these closures without using forceps to grab the skin. Use of the forceps on the skin as much as is possible should be minimized to minimize trauma and ensure a better looking scar. Completing this suture is the same as before, grabbing that free loop and tying it down.